All right, everyone. I'm going to welcome to Updates in Hospital Medicine. I'm going to introduce our speakers. Our first speaker is Dr. Susan Glass, who is a clinical assistant professor for the University of Washington. She is primarily based at the VA and is a frequent lecturer with the Updates in Hospital Medicine program and also helps run the Updates in Hospital Medicine program at the VA. She's also an avid skier. Welcome, Dr. Glass. Our second speaker is Dr. Stephanie Field, who is a clinical assistant professor at the University of Washington, and she works at Harborview Medical Center. She is Washington native who did her residency at the University of Washington, and she's very passionate about delivering high quality care and advancing medical education. She runs the QI program at Harborview. And then the third speaker will be myself. I am Pallavi Arora, and I am one of the hospitalists at Harborview and also a big part of the Updates in Hospital Medicine program and a cat lady. So if you see a cat walk across the screen, you've been warned. I'm going to hand over to Dr. Glass, who's going to start us off.
Thank you so much for that introduction, Dr. Aurora. So yeah, this is Updates in Hospital Medicine for June. And as just kind of a matter of formality, we do not have any disclosures relevant to today's talk. We have a lot of studies to get through. I don't know if any of you have been to these before, but we're going to try to go through some of these studies in detail. We'll have a couple that we just do a quick flash update on. But in general, we're going to be reviewing some of the new evidence for anticoagulation following ablation for AFib, whether it's safe to give IV iron in acute infections, the use of fish oil in patients with end-stage renal disease, frequencies of medication errors after discharge, how we can use clinical decision support tools to impact our naloxone prescriptions, some new data about GLP-1 inhibitors for the treatment of alcohol use disorder, and then looking at antiplatelet monotherapy following PCI. But before we get into the heart of some of these topics, I really want to touch base about this study that made the rounds in all of the news recently. You may have seen it. It was looking at the association between dementia risk and coffee and tea intake. And they found that specifically drinking caffeinated coffee or tea was associated with a lower rate of dementia. This was, an observational study, survey-based nutritional, so not necessarily the best, highest quality data, but in general, for those of us who enjoy our caffeinated coffee or tea in the morning, maybe you have a little bit more reason to do so. It does sound like about the 2 cups of coffee a day was the sweet spot. More than that really didn't buy you a lot more protection. All right, so moving into our first clinical case, we have Miss Wells. She's a 74-year-old woman, has a history of AFib, underwent ablation a couple years ago, and you're admitting her to the hospital for a GI bleed, which is secondary to peptic ulcer disease. Well, she's been in the hospital, you've had her on telemetry, and she hasn't had any evidence of AFib. So she's asking you when it's safe to resume her apixaban. And the question is, does she still need it? So, a little bit of some background. Current guidelines do actually recommend that you continue anticoagulation for patients following ablation for AFib. This is both the American and European guidelines. They recommend doing so based off of somebody's CHA2DS2-VASc score, as you would do in anyone with AFib. And this is unfortunately based on kind of moderate quality evidence without any randomized control trials. So that again begs this question of, is it actually maybe safe to stop anticoagulation in patients who've undergone ablation and have no evidence of AFib recurrence? And this study published in JAMA in August of last year called the ALONE AF trial was the first randomized control trial trying to answer this specific question. So it was an open label superiority randomized control trial in South Korea of almost 900 patients, all who had a history of AFib and had undergone ablation. They had CHADS-2-VASc scores that would typically necessitate being on some kind of anticoagulation. And then they needed to have no evidence of AFib recurrence for at least a year, which in this study they defined as having at least two different cardiac monitors post-ablation, ideally about 6 months apart. And you can see these are the short cardiac monitors, they're not your long 2-week Holters. The population of this trial, so it was mostly male, and I will highlight they were relatively healthy. You can see relatively low rates of comorbidities, hypertension being the most common, and that plays out in the mean CHADS-2-VASc score, which was right around 2. The mean Has-Bled score, similarly also low, right around 2 as well. So patients in the study were randomized to either discontinue their oral anticoagulation or remain on an oral anticoagulant. Most patients in this study were on apixaban or rivaroxaban, and the apixaban could be dose reduced as we typically do for weight, age, and creatinine clearance. There were very few patients that were on any other alternative anticoagulation. And then their outcomes. So the primary outcome of this study was a composite of two different thromboembolic events, stroke and systemic embolism, in addition to major bleeding at 2 years. And that major bleeding is defined in the kind of typical international criteria. Secondary outcomes included a lot of clinically relevant endpoints, including each of those composite endpoints individually, some non-major bleeding, all-cause mortality, hospitalization, etc. So what did they find? Well, they found that there was a significant increase in that primary outcome for the patients who remained on an oral anticoagulant compared to those who had theirs discontinued. You can see that represented graphically here. That blue line are the people that stay on an oral anticoagulant. And there's some divergence in the lines kind of initially, but there's that really acute change right around 18 months. Not surprisingly, this is really mostly driven by bleeding risk, but that is actually still very clinically useful because when they pulled out ischemic stroke and systemic embolism, there was still no difference between the two groups. So stopping the oral anticoagulant didn't increase your risk of stroke or systemic embolism in this study. There were absolutely zero MIs or deaths in either group in this study. And then rates of AFib recurrence were about 10%, so 1 in 10 patients. Um, Limitations of this study. So there were several. It was, in general, a pretty well-designed trial, but open label does leave the risk for some potential bias. I'll also call out there were a relatively low number of events overall, which does raise the concern about it being underpowered, although it's probably pretty typical to what we would see in somebody with those CHADS-2-VASc scores. And that really highlights some of the generalizability issues of this study, which is that this was, in general, I would say a healthier patient population, certainly than what I care for at the VA, but probably than the US healthcare population as a whole. And so that may limit some of the ability to extrapolate this to certain patient populations. And then my only other thing was this composite outcome that combined bleeding and thrombotic events is super practical and is actually like how we manage patients in our clinical settings because we don't start somebody on a blood thinner in isolation saying, okay, I'm only worried about clotting. We worry about clotting and bleeding together. But it does feel a little bit odd in a study where those two endpoints are in opposition to each other and they could potentially cancel each other out. That's not what happened in this trial, especially when they pulled out the data individually, but it is just a little bit unusual. Okay, so my big takeaway for this study is that there are probably patients who have undergone ablation for AFib where they don't have recurrence of AFib and they do not need anticoagulation anymore. And that's probably those patients with this intermediate risk CHADS-2-VASc score. I don't think we can say that this is true without further study for patients that have a higher CHADS-2-VASc score of, say, 5 or 6. But definitely, I think this will impact guidelines in the future. Okay. Back to our clinical case. Miss Wells, unfortunately, while she's in the hospital, develops a hospital-acquired pneumonia. Her blood cultures have been negative for over 48 hours, and you notice that her hemoglobin stabilized around 8 without needing any kind of blood transfusion. But she does have iron studies consistent with iron deficiency, not surprisingly. And you're wondering whether or not it is safe to give her IV iron while she's actively infected. Again, for some background, we have in vitro studies that have shown increased bacterial growth in bacteria who require iron for replication when they're exposed to higher transferrin saturation. But when we've taken that lab study and tried to look at it clinically, we've had conflicting results about the safety of IV iron. And so this question has kind of continued to remain of, is it actually safe to give IV iron when somebody's acutely infected? And this study published in Blood in January of this year was trying to be kind of the definitive study to answer this question. It was a retrospective study, retrospective cohort, pulling EHR data from over 100 healthcare organizations, so huge study. To be included in the trial, patients had to have a diagnosis of either iron deficiency anemia, either iron deficiency anemia and an active infection with antibiotics that were administered within 2 days of the diagnosis of that infection. And that was just a way to try to reduce any potential confounders of people that may have an infection but may not, and they're maybe coded differently in the EHR. They did limit it to kind of specific infectious diagnoses. Again, this was a way to try to make this as clean as possible, but you can see they did include even MRSA bacteremia. The population of this trial, so the initial poll of the data included almost 350,000 different adult patients. You can see almost half of those patients had MRSA bacteremia or pneumonia, so these weren't all just simple cellulitis. But unfortunately, when they had to do propensity matching, they found that there was, not surprisingly, significant differences between the groups of people who received IV iron versus those who did not. And so they were only able to use about 120,000 patients in the actual analysis. There were overall slightly more women than men, and that was especially true with UTIs. Again, not really surprising. And then there were really high rates of comorbidities in this study, so most common being heart failure and CKD. Uh, Patients in the study, so the intervention arm were those patients who received IV iron, and it had to be within 7 days of the iron deficiency anemia and infection diagnosis. And then they compared that to anyone who did not receive IV iron. They actually extended the timeline to 1 month before these diagnoses and 3 months after, again, just to reduce potential confounders. The primary outcome of the study was survival at both 14 and 90 days post-index date. And index date in this study, they defined as the latter of either the iron deficiency anemia or infection diagnosis. Secondary outcomes, really relevant clinical outcomes included in this study, including length of stay, how long patients were on antibiotics, how long they had to be on a ventilator, and how often they received blood transfusions, as well as whether they had hemoglobin recovery. So what did they find? This is a little bit of a busy slide, so I apologize, but this is the graphical representation of that primary outcome of survival probability. And so the y-axis is survival probability. The blue line are patients who received IV iron, and the red line are those who did not receive IV iron. And then each graph is a different infection. But what you can see is, the higher the line, the more likely you are to survive. And so across the board, the patients that received IV iron had a significantly higher survival compared to those who did not. Looking at those secondary outcomes, so IV iron was significantly associated with longer length of stay in several infections. Antibiotic courses were longer across the board in patients who received IV iron, and they were on a ventilator longer in the pneumonia patients. Positively, there were less transfusions in patients who received IV iron, and there was a significant hemoglobin improvement. So the thing we're giving IV iron for did actually, work in this case. And then this was kind of another interesting graph that they included in their study. It's a forest plot where they tried to take all of the primary outcome and then all of those secondary outcomes to determine, risk benefit overall, if it favored giving IV iron or not. And you can see, left side's favoring IV iron. They showed in their data that they felt overall for all of these different infections, despite the kind of potentially longer length of stay and longer antibiotic courses, the data supported giving IV iron. Unfortunately, we have a lot of caveats for this study, and I actually included this just because, it's a question we've had for so long. And I worry that it could be easily misinterpreted. So I'm going to highlight some of these limitations. The biggest issue in this study is bias. So, certainly there's residual confounders and selection potential bias in a retrospective study with this design. But the biggest issue in this study is actually something called immortal time bias, which was something I was not familiar with, but I heard a really good analysis of this study by the Curbsiders. And I'll talk about that in just a second to give you an idea of what that means. But they also didn't have any documentation about adverse events from IV iron. It was unclear how often patients got antibiotics before iron and if that could potentially impact safety. We don't know how much IV iron was actually administered or if people received oral iron. And then, a variety of other issues. So lots of limitations with this trial. Back to this immortal time bias. So basically, immortal time bias is that patients are essentially getting a survival benefit in this study based on the time of exposure to getting IV iron. And that's because anybody that lived long enough to receive IV iron already has a survival benefit. If they died before IV iron was administered, they were counted in this no IV iron arm. So, you may just be selecting for a population of people that were just sicker from their infection. And so this survival benefit that we're seeing is actually artificial based on how this study was designed. So seeing that, unfortunately, even though I really wanted this to be the study that was definitively telling us it's okay to give IV iron when somebody's actively infected, there's just too many limitations with it. So we just don't have definitive data that can tell you for sure that it's safe one way or another. But overall, I would say the data supports that the risks are probably exaggerated. And so in a case like our patient, where she's been afebrile, she's clinically improving, her blood cultures are negative, that's the person you can probably give IV iron to safely. It's when they're really acutely infected, still sick in the ICU that I would certainly not give them IV iron based on this data alone. All right, so that is me. And I forgot to mention earlier, we should have time for questions at the end, but feel free to drop any questions in the chat and we'll happily try to answer them when we're not speaking. But I will hand it over to Dr. Field.
Thank you, Dr. Glass. So we'll start off with a case. Ms. Sylvia Jones is a 65-year-old woman with hypertension and end-stage renal disease on dialysis who was admitted for an NSTEMI. She asks if she should take a fish oil supplement. So do fish oil supplements benefit patients who are on hemodialysis? The study published in the New England Journal of Medicine in November 2025 looked at fish oil supplementation and cardiovascular events in patients on hemodialysis. They asked, does supplementation with fish oil reduce cardiovascular events in patients receiving hemodialysis? So for background, we know that cardiovascular disease is the leading cause of death in patients on hemodialysis. And we know that supplementation with fish oil may have cardiovascular benefits in the general population, but efficacy in hemodialysis patients is uncertain. Their population was 1,228 adult patients receiving maintenance dialysis 3 to 4 times a week for end-stage renal disease. The study was conducted at 26 sites in Canada and Australia. The patients were clinically stable before enrollment. They excluded patients with heart failure, systolic blood pressure over 180, an ICD, or a recent hospitalization. The characteristics were similar in the intervention and comparison groups. Average age of 64 years old, 63% male, mean duration of hemodialysis 3.7 years, 55% had diabetes, 85% had hypertension, 35% had a history of cardiovascular disease, and 55% were on a statin. The intervention was a daily oral supplementation with fish oil compared with the placebo. Specifically, the fish oil was a 4-gram N3 polyunsaturated fatty acid containing 1.6 grams of EPA and 0.8 grams of DHA. Participants were followed for up to 3.5 years. Their outcomes were for the primary outcome, a composite of all cardiovascular events, including sudden and non-sudden cardiac death, fatal and non-fatal MI, peripheral vascular disease leading to amputation, and fatal and non-fatal stroke. Their secondary outcomes were First of all, another composite, which was an extension of a primary endpoint to include non-cardiac causes of death. They looked at each individual component of the primary endpoint, also looked at a first cardiovascular event and death from any cause. So here's what they found. For the primary endpoint, the composite of cardiovascular events, patients taking fish oil had fewer events than those taking placebo, with a hazard ratio of 0.57. So the event was 43% less likely to happen in the fish oil group, with a confidence interval not crossing 1. They did the subgroup analyses, dividing the population into whether they had a prior cardiovascular event or not. The hazard ratio for the primary outcome was similar and remains significant. The secondary endpoints of the components of the primary endpoint and the primary endpoint plus non-cardiac death were all also better in the fish oil group. The only endpoint they looked at that was not significant was death from any cause. You can see here that the hazard ratio crosses 1. And then this is a bar graph of each of the components of the primary outcome: cardiac death, fatal and non-fatal MI, peripheral vascular disease leading to amputation, and fatal and non-fatal stroke. The blue is patients taking fish oil, the gray is patients taking placebo, with the y-axis the percentage of patients with each event. So you can see that each event is lower in the fish oil group. And then here we see the events over time. The shaded areas are 95% confidence intervals. On the left, we have the mean cumulative number of events per patient over time, and you can see that there are fewer in the group taking fish oil. On the right, we have event-free survival over time. There were some limitations to this study. People who switched to peritoneal dialysis or had a kidney transplant were removed from the trial, so we do not know if these findings would be true for those groups. They did not track whether participants in each group took over-the-counter fish oil in addition to the study drug. So I believe if they did, though, it would bias towards the null. They did not adjudicate bleeding events, though they said it seemed lower in the intervention group. This is pertinent because historically there's been concern for fish oil causing bleeding, but more recently there are trials that suggest the opposite. And finally, I think the main limitation to the study is that the study drug was a very specific 4-gram polyunsaturated fatty acid, which included 1.6 grams of EPA and 0.8 grams of DHA, which is just not what you can buy over the counter. Most over-the-counter fish oil is 1 to 2 grams and does not necessarily have those components. So for the takeaway, rates of serious cardiovascular events were significantly lower in hemodialysis patients who received these fish oil supplements compared to placebo. I like the trial design. I think that despite its limitations, it is worth advising patients who are receiving hemodialysis to take fish oil. In my hospital medicine practice, it's helpful to know this benefit so that I can continue the medication for my patients. And I think that even though patients who were recently hospitalized were excluded from this trial, it's reasonable to recommend this as a new start in the hospital because there is pretty much no downside noted to this. All right, next I have 4 flash updates. The first is the 2026 ACC/AHA lipid guidelines. There are many changes to the lipid guidelines this year. In general, we want to screen and risk stratify earlier, start statins earlier, and push LDL lower. So we want to start checking lipid panels at age 19, repeat that every 5 years. Use the Prevent ASCVD calculator to estimate cardiovascular risk starting at age 30. And then start statins at age 30 for people who have an intermediate and high 10-year risk. Consider statins for those with borderline risk. Start statins for those age 30 with an LDL greater than 160, a strong family history of premature ASCVD, or a high 30-year risk of ASCVD, even if their 10-year risk is low. We have lower LDL goals. We want the LDL less than 100 for patients with low, borderline, or intermediate risk and no clinical ASCVD, less than 70 for patients with high risk or the small amount of patients with clinical ASCVD who are not very high risk, and less than 55 for most patients with clinical ASCVD. We also want to check lipoprotein A once for everyone and consider coronary artery calcium scoring and ApoB testing. Next, this is a summary from JHM of the 2025 ACC/AHA Acute Coronary Syndrome Management Guideline. The main thing to take away here is that patients with ACS who have an LDL greater than or equal to 70 despite max dose statin should have a non-statin lipid-lowering agent added. Next, This is a prospective cohort study published in JGIM, which looked at how often older adults make medication errors after discharge when a change was made to their antihypertensive or glucose-lowering medication. This was a survey-based study. They found that 40% of patients had a medication error at 7 days after the discharge. They asked in the survey whether patients were advised to follow up in clinic, which is the yellow bar you see here in this graph, whether they were advised to check blood pressure or blood sugar, the orange bar, whether they were educated on medication side effects, the blue bar, or if all of those three things happened, the light blue bar. You can see mostly patients were advised to follow up, but only half were advised to check blood pressure and blood sugar, and they were rarely educated on medication side effects. So this study reminds us that it's very common for patients to make medication errors on discharge, and discharge counseling from clinical teams is lacking, and we should take steps to improve it. And finally, this study was also published in JGIM. A group out of University of Colorado implemented an interruptive clinical decision support tool for co-prescribing naloxone with high-risk opioid prescriptions, which resulted in more naloxone prescriptions. This is the CDS here that you see. And then this graph shows the naloxone prescriptions per week over years. The vertical gray dotted line is when the CDS was implemented, so you can see that the naloxone prescriptions increased afterwards. This does not show the naloxone prescription per high-risk opioid encounter, which would be a better measurement. But still, I think it's an interesting idea that we could all work to implement at our own hospitals to increase naloxone prescribing for our patients on opioids. Thank you. I will pass off to Dr. Aurora.
Thank you, Dr. Field. So I am going to start with a clinical case. This is a 65-year-old man with obesity and severe alcohol use disorder, also has coronary artery disease. He drinks 6 packs of beer each night and has been doing so for the last 20 years. His vitals in the clinic are stable. There are no notable exam findings except for a BMI of 31 kilograms per meter square. He is requesting help with alcohol use disorder. He has tried acamprosate and naltrexone without benefit, and he doesn't want to try disabuse medicine. So the question here is that, is GLP-1 receptor agonist therapy helpful for severe alcohol use disorder? And in order to answer that question, this study was conducted and was published in The Lancet in May 2026. This is once weekly semaglutide versus placebo in patients with alcohol use disorder and comorbid obesity. So what did they do in this? So just before we go to the study, a little bit of background. So we all know from observational data that GLP-1 receptor agonists work on reward pathways and have some role, possibly have some role in substance use disorders. But there have actually only been 2 RCTs published thus far, actually studying the role of GLP-1 receptor agonists. They were both published in the American Journal of Psychiatry in 2025. The first one was the use of exenatide in treatment-seeking patients with alcohol use disorder. And surprisingly, this study did not show any effect on heavy drinking days. However, there seemed to be a signal for benefit in patients with BMI greater than 30. The second RCT used low-dose semaglutide, but these were non-treatment seeking individuals with alcohol use disorder. Again, surprisingly, semaglutide did not affect the average drinks per calendar day and did not affect the number of drinking days, but there was a significant reduction in alcohol intake in a laboratory self-administration task. So I had to look up what this is. And this is, you're put in a laboratory, you have your drink of choice with the brand of choice in front of you. You have to try to abstain for 60 minutes. And then after 60 minutes, you can drink as much as you want over the next 2 hours. And then they kind of assess the amount of alcohol intake. So again, non-treatment seeking individuals in a controlled environment. So this study was real world, randomized, double-blind, placebo-controlled in a single center in Denmark. They had patients with moderate or severe alcohol use disorder who wanted help to decrease alcohol consumption. All patients had a BMI greater than 30. They were randomized to once weekly semaglutide or once weekly saline injection. Both groups got 10 standardized sessions of cognitive behavioral therapy, which has good empirical evidence for alcohol use disorder. The study duration was 26 weeks. What I wanted to highlight was that 85% of the patients actually had severe alcohol use disorder per DSM-5 criteria. So mostly the population was severe alcohol use disorder. The primary endpoint was a reduction in the number of heavy drinking days from baseline to week 26. And the way they calculate heavy drinking days is the number of days that you had heavy drinking, which is greater than 4 drinks for a female and greater than 5 alcoholic drinks for male in the last 30 days. The average for our study population was 17.6. So what did they find? They found that semaglutide decreased the heavy drinking days by 41 percentage points. And the placebo, there was a placebo effect as well. So those in the saline injection group had a 26% decrease in heavy drinking days. This was a statistically significant difference of about 14 percentage points. If you look at the graph, on the x-axis is time in weeks, and then the placebo is in blue and the semaglutide is in red. And you can see that the two lines actually diverge only after 6 weeks. This is because the semaglutide group, they started with a low dose and then gradually built it up as they were tolerating it. So it took about 6 weeks before the curves diverged. But once they did, they stayed at about the 14 percentage points of difference. So that makes the number needed to treat for semaglutide 4.3 to affect a 2-level decrease in WHO risk drinking level. So 2 things I wanted to say about that. So for the traditionally used medications like acamprosate and naltrexone, the number needed to treat is greater than 7. The second thing is that for alcohol use trials, the FDA has accepted these decrease in WHO risk drinking level as opposed to abstinence as an endpoint. So the number needed to treat is not for those patients that were completely abstained from alcohol, but even a decrease in your drinking is considered a positive outcome. The adverse events were as expected, more in the semaglutide group. They were mild to moderate GI effects and they were transient. So the limitations of this study, predominantly white population, single center in Denmark. We don't know if this is generalizable to patients with BMI less than 30. There is the functional unblinding in incretin therapy trials. So by week 6, patients know whether they are in the semaglutide group or the saline injection group just by virtue of decrease in appetite and loss of weight. Would think that the providers who were administering the CBT also probably could tell which patients were in which group. So how that influences the behavior of the patients is also something to take into account. And then we don't have any follow-up data after week 26. So it's unclear if there is any long-term sustained benefit of the semaglutide after discontinuation, or if you just have to be on the medication lifelong in order to keep that level of alcohol intake, lower level of alcohol intake. So the take home is that once weekly semaglutide reduces heavy drinking days and the WHO risk drinking levels in treatment seeking patients with alcohol use disorder and comorbid obesity. So I think that GLP-1 receptor agonists are a promising option for severe alcohol use disorder in obese patients. I don't know if this has yet reached the point where insurance will approve this. This second study I have is a flash update, staying with our GLP-1 receptor agonist. There is a new kid on the block. It's called orforglipron. It's an oral GLP-1 receptor agonist. And we know that semaglutide is the only other GLP-1 receptor agonist available in the oral formulation. So this study was comparing the two. Just for background, GLP-1 receptor agonists are peptide-based molecules, so they have to be administered via subcutaneous injection in order to allow absorption, avoid degradation in the GI tract, and the first-pass metabolism. What I didn't know, so I did know that oral semaglutide is co-formulated with an absorption enhancer, but I didn't know that its bioavailability is just 1 to 2%. And it has to be taken in a fasted state with no more than 120 ml of water at least 30 minutes before food, coffee, or any other medication. So certainly something that would for hard to do for something that has pretty low bioavailability. Orforglipron is sort of this non-peptide GLP receptor agonist, so it doesn't undergo degradation in the GI tract, and so you can have oral administration without food or water restrictions, and it's fairly long acting, so it's amenable to once daily administration. So this was a non-inferiority trial, and because this is a flash update, I'll spare you the details, but the primary objective of non-inferiority was met. Interestingly, so the orforglipron, both the doses that they tried had patients taking that medication had a greater decrease in the HbA1c compared to the semaglutide group. Interestingly, there were more GI side effects in the orforglipron group, and that resulted often in discontinuation of the study treatment. So I think it's to be determined how we will use this medication, but I just wanted folks to be aware of it. The next study that I wanted to highlight, go back to our case, the same 65-year-old guy. He has obesity and coronary artery disease. He's had a PCI with a drug-eluting stent to his RCA in, well, let's say 2019. I was supposed to say 2019. At baseline, he is on goal-directed medical therapy with aspirin, statin, a beta blocker, and ARB. His vitals are within normal limits. His physical exam is without notable finding. He has no cardiac symptoms, and he's had a recent stress test and TTE without evidence of inducible ischemia or structural disease. And he said he feels very strongly that the aspirin causes some GI side effect, and he's having a lot of bruising, and he's wondering if at this point he can switch to some other medication and just stop the aspirin altogether. So the question here is clopidogrel a safe and effective alternative to aspirin for secondary prevention in stable CAD? And this article was published in The Lancet in April 2026, and it is the 10-year follow-up of the HOST exam trial, looking at aspirin versus clopidogrel for chronic maintenance monotherapy after PCI. So for background, we know that data from trials indicates lower rates of clinical events with clopidogrel than with aspirin monotherapy for secondary prevention of PCI. However, we only have a short to intermediate term follow-up between 2.3 and 5 years in the STOP-DAPT-2, Smart Choice 3, and the HOST exam trials. It's only up to 5 years follow-up. Secondary prevention for PCI is continued lifelong. And so this article and this study was hoping to fill the gap on whether this is still effective after 5 years. So this was the 10-year follow-up. This is a prospective randomized open label multi-center trial, but all the centers were in South Korea. They had adult patients who had had a PCI with the drug-eluting stent. They had completed 6 to 18 months of dual antiplatelet therapy as prescribed and guided by their cardiologist. And when it came to randomization, they were randomized to either aspirin monotherapy or clopidogrel monotherapy. This was 5,438 patients, so about 2,700 patients in each group. And the investigators, they followed these patients annually for 10 years and had a really good completion rate of 92.8%. There was, however, only 75% adherence to protocol. So only about 2,100 patients in each group adhered to protocol. And this was because oftentimes patients developed atrial fibrillation or other indications for anticoagulation. So the antiplatelet was stopped and anticoagulation was continued. There were some patients who switched from the aspirin to the clopidogrel arm, but the analysis was done in an intention to treat protocol. The groups were well matched at baseline, and the primary endpoint was this similar composite endpoint, like Susie mentioned. It included all-cause death, non-fatal MI, readmission for ACS, as well as severe bleeding, BARC greater than or equal to 3 type bleeding, which is if you need a transfusion, if your hemoglobin drops greater than 4 points, if you have an intracranial bleed, so severe bleeding. So what did they find? They found that even beyond the 5 years, clopidogrel group had a lower rate of the primary composite endpoint than aspirin. So it was about 25.4% in the clopidogrel group and 28.5% in the aspirin group. So if you look at the graph, that's a hazard ratio of 0.86, and the number needed to treat was 33. So 33 patients with clopidogrel to prevent one adverse composite outcome. The host exam investigators had done an interim analysis at 2 years and found no difference between aspirin and clopidogrel. But the curves continue to diverge even at 10 years. So there is some cumulative benefit of clopidogrel monotherapy over aspirin, and it seems like you need to take it for at least 2 years before you start having the benefit. What I wanted to highlight in the secondary outcomes was that this change or this benefit was not driven by mortality. The mortality was same in both groups. It was driven by a lower rate of thrombotic endpoint in the clopidogrel group, primarily lower rates of non-fatal stroke and readmission for ACS. Clopidogrel group also had a lower rate of bleeding, interestingly. So the concern for bleeding with clopidogrel was assuaged. And a lot of patients on aspirin monotherapy do have GI side effects and bruising. Limitations, it was an open label design, even though the outcomes were hard, so less likely to influence the assessments. But it was all Korean patients, and so this limits generalizability to non-Asian populations. Even so, I think that my conclusion from this is that clopidogrel monotherapy is associated with significantly lower all-cause death, non-fatal MI, stroke, readmission for ACS, and bleeding compared to aspirin monotherapy. In fact, the European guidelines from 2024 give clopidogrel a class 1 recommendation for long-term maintenance in stable PCI for secondary prevention. So something for us to maybe start implementing in our practice. I have 2 more flash updates before the end of the, 3 more flash updates before the end of the talk, 2 from me and 1 from Susie. This was an interesting retrospective cohort study that was published in American Journal of Cardiology, and it basically talks about the impact of mitral annular calcification on heart failure with preserved ejection fraction. So they mined this big database, and they one of the ways that they studied this database was that they took all patients and stratified them by those that had mitral annular calcification and those that didn't, and followed them for 1 year. And they found that patients with MAC were much more likely to develop heart failure preserved ejection fraction than those without MAC. They also then stratified patients with heart failure preserved ejection fraction into those that had mitral annular calcification and those that did not, and followed these patients and found that the patients with MAC were much more likely to get admitted for a heart failure exacerbation, for all-cause hospitalization, and various other cardiovascular outcomes. So the presence of MAC somehow indicates a much sicker heart failure preserved ejection fraction patient. So the conclusion is that MAC, in addition to all the other risk factors, is also an independent risk factor for heart failure preserved EF. And then if you have heart failure preserved EF and you have MAC, you are at higher risk of adverse outcomes. Nothing actionable, but it's definitely something that I'm going to note in echocardiogram studies and maybe speak to my cardiology colleagues about if something needs to be done. The second flash update is talking about GLP-1 receptor agonist therapy and SGLT2 inhibitor therapy in patients post-TAVR. So we have obviously more and more patients who are receiving TAVR as the indications expand for lower and lower risk aortic stenosis. Medical therapy after TAVR is understudied, and we know that these diabetic medications should have cardioprotective effects. So this was a retrospective cohort study, and they looked at all patients post TAVR and stratified them into those that received GLP-1 receptor agonist therapy, those that received SGLT2 receptor agonist therapy, those that received neither, and those that received both. And what was really mind-blowing for me was that those patients post-TAVR that got GLP-1 receptor agonist therapy had a decrease in all-cause mortality, 6% versus 8.6%. Patients who were on SGLT2 inhibitors post-TAVR had a significant decrease in arrhythmia compared to those who were not. And when you combined the two, there was a additive benefit of decrease in all-cause mortality as well as arrhythmia in the post-TAVR patients. The thing that was sad was that post-TAVR, there were only 6.8% patients that received SGLT2 monotherapy. Only 1.4% patients were on GLP-1 receptor agonists, and only 1% on combined therapy. So certainly a lot of work to be done in this area. All right, Susie, all you.
All right, so last update, and this is just a really quick flash study. This was published in New England Journal. It was a study looking at whether or not patients who have chronic coronary disease can have their aspirin discontinued if they need an oral anticoagulant for some other reason. And they did a composite endpoint in this study, as they do with all of them now. But this one was primarily focused on thromboembolic endpoints. You can see as cardiovascular death, MI, stroke, systemic embolism, and whether or not they needed to get revascularized or acute limb ischemia. And they found that that composite endpoint was actually higher in the aspirin group, which seems a little bit counterintuitive. My guess is that people probably bled and had to have their aspirin discontinued, and the bleeding itself was some kind of like also prothrombotic event just from inflammation in the setting of that process or being in the hospital. Not teased out in the data, but there was a higher all-cause death in patients on aspirin and definitely bleeding. So just kind of more data. I feel like increasingly we're seeing a lot of data about aspirin is maybe not the best drug anymore now that we have more and more things. And certainly when people are on multiple medications that make them at risk for bleeding, it may be more harmful than beneficial. I'm not sure that this is truly actionable yet because it's one study and until it's guidelines, I don't know how quickly we'll adopt this, but I will say for like a patient coming in who's bleeding and you're having to choose, at least you have some data to say, hey, maybe the aspirin's actually harmful anyway, and let's just leave you on your oral anticoagulant. All right, we have some time for questions, but certainly if anyone has questions, you can afterwards, you can definitely email. Happy to talk through anything at any point. So,
Yeah, absolutely.